This is the place where we take on some of the most critical and sometimes difficult topics. We cut through the noise and really try to deliver the essential insights you need.
And today we are definitely doing that.
We are. Today we're undertaking a deep dive into what many of our sources are calling the most urgent public health crisis in the United States.
Yeah.
And that's the profound, frankly, unacceptable disparity in Black maternal health and birth outcomes when you compare them to those of white women. The data is shocking, and the implications, as we'll see, are completely systemic.
And this deep dive, it's built on sources from some really rigorous health research, data science, and critically Black feminist sociology.
Right.
And the story that these sources are telling is, well, it's stark, it's painful, and it goes so much deeper than just the surface level statistics you might have seen.
Exactly. We're going to be looking at the structural, the institutional factors that result in Black women facing these disproportionately high numbers of adverse outcomes.
And our mission for this deep dive is, I think, really clear.
It has to be. We need to move past just saying, oh, a disparity exists, and really dig in to understand the difference in mortality and morbidity rates.
We want to pinpoint the root causes.
Yes, the root causes, which, and this is crucial, the source material makes absolutely clear, have very little to do with biology.
So little.
And then, most importantly, we want to explore the evidence-informed, often community-led paths toward real, meaningful, systemic change.
So to get started, we have to set the context. I mean, that's the starting point for any rigorous analysis, right?
Of course.
And the essential context here is that this issue is fundamentally structural. It is not merely a clinical problem.
Okay, so when you say structural, what are we seeing? What are the outcomes?
Well, when we look at the adverse outcomes, you see these disproportionately high rates of low birth weight babies, unnecessary C-sections, severe complications during birth, premature births, a lack of timely prenatal screenings. What you're seeing are the symptoms of a fractured social system. You're not seeing inherent biological weakness. That's a critical distinction.
And the language we use to talk about this, it matters so much. Our sources show that when we frame this as a crisis, we're actually reflecting the way movements like Black Lives Matter have positioned Black motherhood itself.
As in crisis.
Exactly, in crisis. That framing, making visible these issues like Black infant mortality, Black maternal mortality, and this very real phenomenon of obstetric violence, it immediately shifts the narrative.
It does. It shifts it away from any idea of individual failure and puts the focus squarely on systemic accountability.
It recognizes the profound urgency, the failure of our institutions to protect Black mothers, and that's where we have to start.
Okay, so to really understand why this difference in birth mortality and these poor outcomes are so persistent, so severe, we have to completely shift how we try to explain it.
Right. Because for decades, the focus was often put on individual risk factors, wasn't it?
It was. Things like education level, diet, or lifestyle choices, which kind of implies personal responsibility.
The idea that if you just did something different, the outcome would be different.
Precisely. But the sources we're looking at demand that we focus instead on the systemic drivers. And the core explanatory mechanism here is what's called structural racism.
Which is sometimes used interchangeably with systemic racism.
Yes.
Okay, so let's unpack that. Let's really break down that structural element with the rigor it deserves. How do the source materials define structural racism in this context? I mean, how does it translate to a mother sitting in a clinic today?
Structural racism refers to this vast interlocking network of policies, court decisions, programs, institutional practices, both historical and contemporary.
Okay.
And what this network does is it actively facilitates the economic and social upward mobility of white people, while at the same time, it's creating these sustained, powerful, and often invisible barriers for people of color.
You mentioned the historical context. That's so important. How does a policy from, say, the 1930s impact a pregnant woman in 2024?
It's a great question. Let's take the example of redlining. Decades ago, you had these federally backed policies that designated Black neighborhoods as high risk, and that systematically starved them of investment, of loans, of opportunities to build wealth. That one policy created an enduring structural barrier.
And we still see the effects.
We absolutely do. Today, the residual effects of that mean that Black women are more likely to live in neighborhoods with inadequate infrastructure, greater exposure to environmental toxins.
Like lead paint or polluted air.
Exactly.
Yeah.
And fewer high-quality healthcare facilities. The lack of generational wealth means less capacity to move, less flexibility in managing time off work for appointments,
Right.
and just a higher level of overall economic stress.
So the structural domain is setting the stage. It's dictating the resources, the environment, and the stress level of the mother before she even conceives.
Yeah.
It's laying the groundwork for poor outcomes from the very beginning.
Precisely. And when you look at maternal health through that lens, you see the institutionalized racism, coupled with things like classism, heterosexism, and a really pervasive lack of cultural humility within the healthcare system itself.
Right.
Those are the forces responsible for the inadequate, inconsistent, and frankly, often dangerous healthcare that Black women receive. The system is just. It's designed to provide optimal care for one population, while it places all these unnecessary and dangerous hurdles in front of another.
Okay, but how does that constant systemic disadvantage, this, relentless stream of policy-driven stress and resource deprivation, how does that translate from the socioeconomic world into actual measurable physiological harm? This is where the concept of weathering becomes so critical.
It's absolutely critical. And weathering isn't a theory. It's a proven biological phenomenon developed by Dr. Arline Geronimus.
Okay.
It describes a mechanism by which the physical health of African-American women begins to deteriorate prematurely. We're talking often starting in early adulthood when you compare it to their white counterparts.
And this isn't just, feeling tired. This is a measurable physical thing.
It is a direct, measurable physical consequence of that cumulative socioeconomic disadvantage and the chronic stress of just navigating these structurally racist conditions day in and day out.
It's like the body's alarm system is just stuck on high for years and years. So what are the specific biomarkers? What do the sources cite that proves this accelerated aging and physical decline?
The research points to several key biomarkers of this chronic low-grade stress that link directly to weathering. The primary one is something called allostatic load.
Allostatic load.
Yeah, so allostasis is the body's process of maintaining stability through change. Allostatic load is the cumulative wear and tear on all of your body's systems, your cardiovascular, metabolic, immune systems, that results from repeatedly having to adapt to stress.
So the system is just constantly being taxed.
Constantly. And a high allostatic load correlates directly with worse pregnancy outcomes, including things like preeclampsia and preterm birth.
So the stress of the system is literally preparing the body for a worse outcome.
In a way, yes. And there are other biological markers, too. There's evidence of accelerated aging right at the cellular level.
What does that look like?
It looks like telomere shortening. Telomeres are these little protective caps on the ends of your chromosomes. Shorter telomeres indicate biological aging.
Okay.
And studies consistently show that African American women exhibit shorter telomere lengths, meaning their cells are literally aging faster than white women of the same chronological age.
Even when you control for other factors.
Even when you control for traditional risk factors like smoking or obesity. This is the physical signature of structural racism written on the body.
That is just. It's profound. It means the constant strain of existing in a system that's built against you is wearing down the body's fundamental mechanisms years before it should. And that makes the already high-stakes event of pregnancy inherently more dangerous.
Exactly.
And our sources point out something critical here. These non-medical factors, what are often called the social determinants of health, are massive drivers of outcomes.
Huge. One expert noted that the political and economic policies driving these social determinants, we're talking about housing stability, access to reliable transportation, neighborhood safety, quality childcare, they influence up to 60% of health outcomes outside of the clinical environment.
60%, that's a majority.
It's a huge majority. It means that most of the risk faced by a pregnant Black woman isn't about her genetics. And it's not solely about the moment she receives clinical care. It's about the political and economic context of her entire life. A context that has been structurally compromised for generations.
So we've got the structural context imposing the disadvantage, and we have the physiological result, which is weathering. How do we synthesize all these layers of oppression to really understand the full magnitude of the issue, in a way that allows us to intervene effectively?
We synthesize them using a really critical framework from Black feminist sociology. It's Patricia Hill Collins' Matrix of Domination.
The Matrix of Domination.
Yes. Collins describes how systems of power like race, gender, and class, they don't operate in isolation. They're mutually reinforcing. They mesh together across different social spaces, and they multiply the effects of oppression.
So it's not just one thing, it's how they all interact.
Exactly. Understanding the matrix is essential because it shows us that oppression isn't just a single lever you can pull. It's a machine with 4 interconnected domains operating all at the same time.
Okay, so let's lay those out. Let's ground them in the maternal health experience. Start with the structural domain.
The structural domain is the arena of macro-level organization. So we're talking laws, policies, state institutions, economic systems,
Right.
the things that organize and codify oppression.
In maternal health, that would be.
That would be the laws that determine who qualifies for Medicaid, the political decisions that close rural hospitals, the lack of funding for specialized care in historically marginalized areas. These structures determine your geographic access to quality care.
Okay, that makes sense. And the second is the disciplinary domain.
Yes, the disciplinary domain is all about the management and control of people. It often operates through surveillance, rules, and punishment.
And in the context of pregnancy.
You see it in things like drug testing policies during labor that disproportionately target Black mothers. You see it in the rise of chemical endangerment laws that criminalize pregnancy outcomes, and just the constant monitoring of marginalized groups by powerful institutions.
So the state is using the pregnancy itself as a site of potential control.
That's a perfect way to put it.
Then we have the third domain, the hegemonic domain, which is more about ideology, right? Culture controlling images. This shapes how Black women are seen before they even open their mouths.
This is where the societal narrative lives. It's the realm of belief systems, the cultural assumptions that justify inequality.
Like what?
Think of the long-standing racist stereotype of the strong Black woman who's supposedly impervious to pain, or the assumption of noncompliance. This narrative permeates clinical training, and it absolutely shapes how a doctor might perceive a Black patient's description of severe pain.
It leads to the dismissal of crucial symptoms.
Tests. This ideological foundation justifies the actions in all the other domains.
And finally, the interpersonal domain. This is the face-to-face, right? This is where all that systemic and ideological bias actually plays out.
This is where it all converges in the delivery room. The structural policy, the disciplinary threat, the hegemonic stereotype. It comes together in these everyday encounters where racial, gender, and class assumptions are enacted.
The dismissive tone.
The dismissive tone, the hurried consultation, the failure to obtain truly informed consent. Understanding this matrix is so crucial because it shows us that we're fighting oppression on 4 fronts at the same time.
Right. So an intervention in one area, say improving access on the structural level, isn't enough if you don't also address the dismissal of pain on the interpersonal level.
You have to address all of them.
This analysis of the matrix of domination is so helpful because it helps us move beyond thinking about this as just individual prejudice. We can see how bias is literally coded into institutional practices.
Right, often hidden deep inside the clinical and technological tools that are supposed to be objective, supposed to be value neutral.
And this is where it gets really interesting when we talk about data science. We have to reckon with how these inherent race-based biases are built directly into medical practice, reinforcing false stereotypes and leading to improper treatment or, dangerously late diagnoses.
That is the insidious nature of modern systemic racism in healthcare. I mean, when technology meets bias, the result is the mass automation of disparity.
The automation of disparity, wow.
Yeah, as researchers point out, race is often used as this crude proxy for socioeconomic disparities. But when you code it into an algorithm, you embed the bias, and the technology appears objective even while it's perpetuating harm.
And the source material gives us a really striking, concrete example of this that has affected countless people. And that's the use of race in algorithms designed to measure kidney function.
Yes, specifically the estimated glomerular filtration rate, or eGFR.
The eGFR.
This algorithm is critical. It measures how well your kidneys are filtering waste using creatinine levels. When this formula was widely implemented, the creators included race as an adjustment factor in the calculation.
An adjustment factor? Why?
Well, this was done based on a widely held but entirely false assumption about Black physiology.
Okay, what was the specific racialized assumption that they coded in?
The clinical community assumed that, in general, African-American people had higher baseline creatinine levels.
And why did they assume that?
Because creatinine is a byproduct of muscle metabolism, and doctors wrongly assumed that African-American people had, on average, a greater overall muscle mass compared to the rest of the population. So they tried to adjust the score upward to account for this presumed difference.
So wait, they took a crude, generalized, race-based stereotype,
Yes.
not based on rigorous individual measurements of a person's body, but on a generalization about an entire group's body composition. And they built that directly into a critical medical diagnostic tool used all over the world.
That is exactly what happened. And the consequence of this false equivalence was devastating for millions of Black patients.
How so?
Because the algorithm assumed they had higher baseline creatinine just because of their race, it artificially inflated their resulting eGFR score. It essentially gave Black patients a better kidney function score than they actually had.
Which directly led to?
It directly led to the underdiagnosis and delayed treatment of kidney disease in the Black population for decades.
It's just staggering to think about the cumulative effect of that one bias calculation. Years of delayed diagnosis, delayed eligibility for kidney transplants, missed critical interventions, all based on a single false racist assumption.
And that institutional damage led to a massive, years-long political and ethical fight. Researchers and activists had to campaign so hard to have the race variable removed entirely.
Which finally happened in recent years in major hospital systems.
It did. But the resistance to removing it reveals the inertia within the medical establishment. It shows how these clinical habits, once they're coded in, become almost impossible to uproot, even when they're proven to be dead wrong.
And this is where the data politics really come into play, because race has always been routinely collected demographic data in healthcare. That makes it so easy to just drop it into these systems.
It's easy, and because it's available, it becomes dangerously entrenched in decision-making, often under the guise of trying to adjust for disparities.
Right.
But the crucial flaw, as we've said, is that race is a social construct. It's not a biological mechanism. Instead of relying on race as a fixed biological factor, objective algorithms should be incorporating the actual non-medical factors, the social determinants of health that we know influence outcomes.
Housing stability, financial security.
Exactly. Neighborhood safety. When you fail to include that messy, difficult, but necessary social data, you end up just relying on the convenient but poisonous shortcut of race.
And this issue, it extends beyond just clinical algorithms and into research itself, leading to what some scholars are calling the danger of the new racist science. What's the fundamental danger there?
The danger is redirection. It's misattribution. What this refers to is a trend where researchers are focusing intently on measuring the biological impact of racism.
So looking at changes in brains, epigenomes, cells.
Right, they're looking at all of that without ever looking at the structural racism that caused the impact in the first place. They're studying the scar tissue without analyzing the weapon that caused the wound.
So if structural racism caused the biological damage, the solution shouldn't be to fix the biology of the person who's been oppressed.
It should be to fix the oppression itself.
Right.
Precisely. Yet so much of the research centers on intervening in the bodies of the suffering individuals, maybe through behavioral interventions or drugs, rather than dismantling the social structure that's making them sick.
And this is particularly acute when the research focuses on Black mothers and their children.
Oh, absolutely. The source material highlights this really damaging belief system that drives some of this research.
And what's that belief?
The belief is that Black mothers are targeted because they are somehow, transferring negative environments for generations to come through epigenetic transmission, or that they're failing to help their children cope with the damage from racism and poverty.
So the result is research focused
on fixing Black mothers, which often translates to proposing individual solutions like better parenting classes or stress reduction techniques, which completely ignores that the primary stressor is systemic oppression and the poverty it enforces. It's a profound academic way of shifting the blame from the oppressive structures right back onto the victim.
And that just reinforces the hegemonic domain of the matrix of domination. It's using the veneer of scientific objectivity to basically recreate race as a biological category, even when scientists know it's a social construct.
Okay, so we've mapped the macro structure in Section 1 and the invisible coding of bias in Section 2. Now let's zoom in on that interpersonal domain. This is the arena where all that systemic bias manifests as a lived, often traumatic, reality for Black women interacting with the healthcare system.
This is what's broadly categorized as obstetric violence.
It is.
And this is where we see how hospitals, clinics, individual caregivers, how they routinely and dangerously disregard Black women's expressions of pain and their wishes for their own treatment.
The foundational trust element is just completely eroded because the patient knows, whether it's consciously or subconsciously, that she's entering a system that has been structurally hostile to her.
Right.
The source material details this as a pervasive pattern of microaggressions and dismissal. Black women report being treated as if they're exaggerating their symptoms, being seen as dramatic, or being immediately assumed to be non-compliant with instructions.
And clinicians, who are influenced by those stereotypes from the hegemonic domain, often delay necessary diagnostic tests or pain medication because they are fundamentally doubting the patient's subjective experience of her own body.
They are.
And we really have to bring in the high-profile situations here that illustrate that this institutional failure transcends class or fame. The story of Serena Williams is such a powerful example. Her story almost ended fatally because of biased care, despite her international celebrity status and immense wealth.
That is the critical takeaway of her story. I mean, she had a known specific medical history, a recent pulmonary embolism. She recognized the symptoms of a new one. She felt shortness of breath.
She knew it was happening.
She knew. Yet when she reported her symptoms and demanded a CT scan, she was initially ignored. She was told her pain medication was probably just making her confused.
Unbelievable.
She had to be persistent, even combative, to get the basic level of care that her life depended on. And the source notes this illustrates that fame and wealth do not negate the fundamental impact of institutionalized racism in healthcare.
If she can be ignored.
If she can be ignored, what hope does a financially vulnerable, less privileged woman have?
That individual disregard is terrifying enough. But when we connect it to the broader systems of state control, we realize just how precarious Black pregnancy can be in the U.S.
And this is where Dorothy Roberts' seminal work, Killing the Black Body, provides the chilling, necessary context.
Yeah.
Roberts' analysis focuses on the historical and ongoing use of Black women's reproductive capacity as a tool for state control and punishment. Her work references policies, both historic and ongoing, where Black women have been disproportionately prosecuted for drug use during pregnancy.
So viewing pregnancy not as a health condition, but as a behavior to be surveilled and penalized.
Exactly. And this moves beyond simple neglect into active state coercion.
Absolutely. This punishment of the pregnant body has metastasized into policies that enforce confinement, jail time, forced medical procedures.
Including forced sterilization in some historical cases.
Right. And medical neglect leading to death. The core mechanism is leveraging the pregnancy itself as a justification for criminalization and control.
Often relying on those racist caricatures of the matriarch or the Jezebel to justify the surveillance. In this framework, Black women are at risk of state control and death because they are pregnant, not despite it.
So the care provider is operating within this matrix of domination, where the patient's identity, which is amplified by the pregnancy, makes her a target for the disciplinary state. I mean, that creates an impossible environment for trust and safe care.
It creates an environment where fear of surveillance directly impacts health outcomes. For example, a Black woman might hesitate to disclose crucial information about, say, housing instability or mental health struggles to her doctor.
For fear that her child will be removed or she'll face criminal charges.
Exactly. So this self-censorship, which is driven by that disciplinary domain, further compromises the quality of her care.
And when we talk about justice in this context, we have to recognize that the very pursuit of data, or the lack of it, can be weaponized. The sources make a pretty chilling comparison about the motivation for data collection in general.
They do. It really highlights the tension between profit-driven data collection and accountability-driven data collection.
Right.
Think back to that well-known Target example, where a major retailer could use data science to predict pregnancy to market to expectant mothers.
Right, to sell them things.
The contrast is stark. There is significant profit in knowing whether women are pregnant for retail purposes. But there is seemingly no profit to be made collecting the granular, community-driven data on the women who are dying in childbirth or receiving biased care.
So that financial indifference means the critical data we need to expose and solve the maternal health crisis data on provider bias, on the quality of local care, on patient experience, that data is often missing or it's just undervalued by the powerful systems. So the data that is collected often just reinforces the problem. It doesn't solve it, because the system values profit over protection. Understanding the depth of the problem requires acknowledging these deep structural roots. But the conversation, it has to pivot decisively toward actionable solutions.
Right.
And our sources are very clear on this. The pathways to change must center equity and systemic transformation. And that starts with recognizing where the knowledge and the leadership already reside.
And it's often said that Black women and Black women-led organizations have had the solutions to the maternal health crisis for generations. The key is elevating their voices and their work into the halls of power and into scientific validation.
And we are seeing tangible political action that's trying to do just that. The formation of the Black Maternal Health Caucus, for instance, launched in 2019 by Congresswomen Alma Adams and Lauren Underwood.
That's a powerful example. It is. This caucus explicitly seeks to elevate the crisis in Congress and advance comprehensive policy solutions. They're often focusing on expanding Medicaid coverage, ensuring access to full-spectrum reproductive health, and funding community-based maternal care models.
So that's an intervention in the structural domain.
Exactly. And beyond the political sphere, the intellectual and advocacy leadership is really anchored by organizations like the National Birth Equity Collaborative, or NBEC.
Which was founded by the physician and advocate Joy Creer-Perry.
Right. And NBEC is so crucial because it leads the intellectual charge. It explicitly identifies and challenges racism as the root cause of health inequities. It frames the entire problem within a reproductive justice and health equity framework.
So they're not asking, how can we save this one mother?
No, they're asking, how do we dismantle the structural barriers that put all Black mothers at risk?
So let's look at some specific evidence-based interventions that move beyond the clinic walls and actually target the social and economic conditions that cause weathering in the first place.
This brings us to the really crucial case for community health workers, or CHWs.
Okay.
These are trained, non-clinical personnel. Often they are women who live in the communities they serve, and they provide culturally responsive, holistic support.
And these aren't just volunteers.
Not at all. They are vital interventions targeted toward Black women that acknowledge the pervasive structural forces, racism, classism, heterosexism, and are responsive to the actual social conditions of their lives.
So what specifically does a community health worker do that a standard nurse or a doctor might miss?
They focus on mitigating those social determinants of health that drive that 60% of adverse outcomes we talked about.
Okay.
They help with navigating bureaucratic systems for housing assistance. They help secure food access, find reliable transportation to appointments, address domestic violence, coordinate childcare.
They're stabilizing the external environment.
They are. They're stabilizing the structural oppression. And by doing that, they are directly lowering the allostatic load and mitigating the physiological damage of weathering. They embody a more holistic, communally oriented healthcare model that treats the patient's entire environment.
And beyond that community support, the economic reality is such a powerful force creating stress. Economic empowerment is cited as a crucial vehicle for changing social realities.
Absolutely. Economic autonomy allows Black women to self-determine. That's a core tenet from bell hooks and other Black feminist scholars.
So things like guaranteed income.
Initiatives like guaranteed income or robust wealth transfer programs directly fight the financial stress that feeds the weathering process. Changing the economic landscape, providing stability and financial resources to the household, that is a radical act of dismantling structural oppression.
Okay, now let's pivot back to data. But this time, data used not as a tool for surveillance or for profit, but as a tool for justice and accountability. And this brings us to the Earth app.
The Earth app is a brilliant example of data justice in action. Its founder, Kimberly Seals-Allers, made this foundational distinction. She said people are often focused on how can we save Black women?
Right.
When that approach implies Black women are passive victims who need rescuing, the actual solution isn't saving, it's accountability from the systems that are designed to harm them.
So how does Earth, that's birth with the B for bias removed, how does it work to achieve this transparency and accountability?
Earth is a platform that allows expectant and new parents to review providers, hospitals, and caregivers based on the kind of care people like them received.
So it's a community-driven database.
Exactly. It's focused specifically on race, gender, and class bias. And critically, it gathers high-quality qualitative data, not just checklist scores, but narrative evidence of microaggressions, of dismissal, of differential treatment.
That completely transforms the power dynamic. Instead of data being collected by powerful institutions for surveillance, the data is collected by the marginalized community itself.
To exert power and to inform safe choices for others. It creates this vital guardrail against bias.
So if a provider consistently gets negative reviews from Black mothers reporting dismissal of pain,
that data creates a transparent, public, and actionable record that institutions can't easily ignore. And this moves us toward an approach that incorporates the lived reality of structural bias, rather than just relying on race as some neutral biological factor, like we saw with the eGFR problem.
Finally, let's talk about the philosophical and practical importance of Black feminist sociology, or BFS, in this entire fight. Why is BFS essential, not just as an academic field, but as a revolutionary blueprint for change?
BFS is essential because it provides the intellectual toolkit we need to resist that new racist science we talked about. And it fundamentally revolutionizes the scientific study of the relationship between biology and society.
How does it do that? How does that shift in perspective change the way maternal health studies are conducted?
It fundamentally shapes how knowledge is produced and what knowledge is valued. BFS centers the lived experiences, the perspectives, the values, and the knowledge of Black women. It's the outsider within perspective.
Right.
And this wisdom, which has been cultivated through navigating these oppressive structures for centuries, is prioritized over the traditionally privileged, often white, male medical and sociological knowledge.
So practically, if a hospital board were to adopt a BFS approach to address its maternal mortality gap, what's the very first thing they would stop doing and the very first thing they would start doing?
Okay, they would immediately stop conducting internal investigations that focus solely on clinical error or individual patient behavior.
And they would start?
They would start by creating paid partnerships with local Black women's organizations and community health workers to conduct deep qualitative interviews. They would listen, they would validate, and then they would redesign their protocols from pain management to charting systems based on the wisdom and the trust earned from that community.
So the goal shifts from fixing the patient to fixing the institution.
That's it, exactly.
Yeah.
You know, the deep dive really forces us to conclude that the crisis of Black maternal health isn't some niche medical issue. It is a critical indicator of the profound failures of our entire social structure.
Yeah.
The disparity in outcomes is driven entirely by structural factors. Systemic racism, economic policies, classism, all of it inflicts measurable, chronic physiological harm, what we know as weathering.
And this structural injustice is then codified and maintained in these supposedly neutral systems like the eGFR algorithm or just through profit-driven data neglect.
Right.
Okay, let's unpack this for the listener one last time. If the problem is structural, then the solutions have to be too. We saw that change requires powerful political mobilization.
Like the Black Maternal Health Caucus.
Right, and economic support for self-determination and a revolutionary shift in accountability.
Epitomized by community-led platforms like the Earth app.
It's a comprehensive fight. It's a fight against oppression across all four of those domains of the matrix of domination, all at the same time.
Absolutely. The structural roots have to be dismantled through policy. The physiological toll of weathering has to be acknowledged and mitigated through supportive social interventions like community health workers. And the data systems must be reformed to ensure they dismantle rather than reinforce oppression. This is about justice, not just health.
It is a massive challenge, but the solutions are rooted in this powerful, transformative vision that's offered by Black feminist thought.
And that vision is really the final piece of this deep dive. Black feminist thinkers, notably the Combahee River Collective, stated back in 1977 that if Black women were free, it would mean that everyone else would have to be free, since our freedom would necessitate the destruction of all the systems of oppression. The sources suggest that by centering Black women's experiences, you are necessarily forced to confront the absolute root causes of societal failure.
Which raises the ultimate provocative question about the capacity and maybe the intent of our current systems.
It does. What does viewing all health equity efforts, whether they focus on kidney disease diagnostics, fair housing, or universal childcare, what does viewing all of them through the relentless, specific lens of Black women's maternal outcomes reveal about the true capacity of our healthcare and policy to deliver justice to all?
Wow.
I mean, if we cannot solve this, the most critical indicator of racial and gender injustice in the clinical setting, what hope do we have for achieving justice anywhere else? The health of the entire societal structure is predicated on its capacity to protect and value Black mothers.
That is a powerful and a necessary question to sit with as you consider this material. Thank you for taking this deep dive with us today into the structural roots of the Black maternal health crisis.
We really encourage you to seek out and explore the critical work being done by organizations like the National Birth Equity Collaborative.
And to understand the policies being advanced by the Black Maternal Health Caucus.
Understanding the social determinants of health and recognizing how structural racism manifests in clinical tools is really the essential first step toward demanding accountability and equity from every institution you encounter.
Knowledge is only valuable when it is understood and applied. We hope this conversation provides you with the clarity and context needed to engage with this crisis thoughtfully and effectively. Join us next time for another deep dive.